Unless somebody needs a break. Anybody need a break? Okay, so let's review some of our kidney stuff. So on our kidney, we drew the outer part. What do we call this outer part? Cortex. The inner part was the medulla. In the medulla, we had these pyramids, right? What was at the bottom of the pyramid? Yeah, the papillae. And they go into the small branches. What were the small branches? Yeah, minor. Calyx. Yeah, calyce or calyx. And those fed into the big branches. So the branches in the renal pelvis, and these are called the manger. And then they go out into the ureter. What kind of tissue do we find in the ureter? No? Oh. No? We find cuboidal in the nephron tubules. Oh, keep guessing. No, I'm teasing. I'll just tell you. Transitional. And what do we find in the bladder? Transitional. And what do we find in the urethra? Yeah, stratified squamous. So this is transitional, stratified squamous. All right. So that was this. Then we had our little snake mouth guys here. You guys remember the little snakes? Okay, so let's draw a snake over here. Let me take this off of here. All right. On our snake mouth here. Okay, so this is super simplified. But what's my vessel coming in called? Afferent. What's this? Glomerulus. And what's going out? Efferent. This is my proximal convoluted tubule. This has some of your columnar cuboidal with and columnar found in this area. This area down here, what kind of tissue is found here? Simple squamous, and these guys have specialty cells and they're called podocytes. And podocytes basically have big gaps in them like this. And there's kind of a membrane that holds these together. So podocytes allow for these big gaps, which allow for bigger filtration. So bigger things can fit through there. One of the things we can filter out that we know from like diabetes is glucose. Glucose molecules are pretty big. So they go through these specialty cells that create these basically filtration slits. And these guys are called podocytes. And that's going to allow stuff to filter into the proximal convoluted tubule. What is the function of the proximal convoluted tubule? Let me backtrack a little bit. So how do we filter things? What's the main driving force for filtration from the glomerulus? Yeah, hydrostatic pressure, right? You guys remember that? Hydrostatic pressure, what is that? A volume, yep, we crank up the volume. So what is it? My little roundabout is the glomerulus. What's the little C shape? Bowman's capsule. And collectively, what do I call these? Renal corpuscle. Perfect. Okay, so proximal convoluted tubule. Anything that fits goes within reason. One thing I will tell you is we're going to have some amount of fluid that's going to be kind of bouncing back off of this membrane and some going this way. So we end up with kind of a counter pressure in there. And we're going to look at that in a little more detail. So you're going to have some amount of filtrate. So when I say everything that fits it goes, that's not exactly true because I have enough counter pressure that I keep stuff in my glomerulus. I don't filter everything out of my glomerulus, even though I kind of will make you believe that. You don't. But a lot of good stuff comes out of here. What comes out of here? Ions that we need. What are some good ions that we need? Which two ions we see on the cell membrane all the time? Yeah, potassium, sodium. Those aren't ions, they're molecules though. So I'm going to say organic, some of our organic molecules. Ions, yeah, chloride, calcium, things like that. So we are going to, and water's a big one. These guys right here are good things that may go out because they fit. But we don't want them to hit the bladder. Why? Because we need them in the body. Like take water, for example. Do we want all of our water to filter out to the bladder? No. So the bulk of this good stuff that we really didn't want to filter, but it fit, gets reabsorbed at the proximal convoluted tubule. So that's important to know that this, and it has a lot of columnar cells. What do we know columnar cells do? Absorption, right? So we're going to see absorption of things that we really didn't want to go out yet at the proximal convoluted tubule. Then we come down, what do we call this part? The nephron loop. All right, a couple things about the nephron loop. The descending branch of the nephron loop is highly permeable to water. What does that mean? Water can fit through those tissues. These are my simple cuboidal cells. And they allow water on the descending loop to come out. So, and we're going to see water come out up here at the proximal convoluted tubules and in my descending loop. I'm going to lose a lot of water back out of there. The whole function of the nephron loop is to kind of refine or filtrate. Here, we're not using a very scientific way to move stuff into our urine. We're just cranking the volume up. So now we have to kind of tweak it, adjust it, make it what we want it to be before it hits the bladder. So part of this is that adjustment, adjusting our filtrate. So the descending loop is highly permeable to water. The ascending loop is not permeable to water, but it is permeable to solutes. So I can lose a lot of solutes on this side. I can lose a lot of water on this side, but when I get over here, water is going to stay in, solutes are going to go out. Over here, solutes are going to stay in, water is going to go out. Over here, what is this part over here called? Distal convoluted tubule. And my distal convoluted tubule is the portion that is most affected by hormones and other signals. So this guy gets the most affected by hormones. And what does that mean? It's constantly changing. We can put stuff in it. We can take stuff out. If we put stuff into the nephron tubule, we're going to call it secretion. That's what secretion is putting it in. If we're taking it out, we're going to call it reabsorption. Then it goes down into this part. This part is my collecting duct. And usually you'll have a bunch of nephron tubules that feed into one collecting duct. All right, so that's the big gist of our nephron tubules. When we look at our kidneys, which I erased my kidney here, but if I was looking at the cortex of my kidney, I have a lot of nephron tubules that are kind of up above the cortex or barely go down into the medulla. Most of our nephron tubules are what we call cortical nephrons. So they are in the cortex. So most of them are here. And then we have some that go down all the way, dip down into the medulla like this. These are the least common. Most of your nephron tubules are going to be found on the cortex. But here's the rule of thumb. The deeper I go towards the medulla, the saltier my outside fluid is going to get. And we call that peritubular. So it's peritubular fluid is the fluid outside my nephron tubules. And the closer I get to the medulla, the more salty it is. which if I go back over to here and I talk about water coming out, as I'm dipping towards the medulla, if I have more salt out here, where does water go? To salt, right? Water follows salt. So that is why as I get salty, water is going to leave my nephron tubules. This salty medulla is pulling the water back out of my filtrate that it went in here. All right, so this was my super simple. Oh, let me talk about one more thing on this. When I have capillaries that kind of go around these are called my paratubular capillaries that go up here around my proximal distal convoluted tubules. The ones that go down here around the nephron tubules are called the vasa recta. I love the urinary system. I think it works so much on concentration gradients. It's like super fascinating to me. Okay, so let me clean my drawing up a little bit here. Does this make sense so far though? Okay. Now I'm going to go back to our blood vessel. Let me just redraw this. It might be easier. Now I'm going to be looking at my nephron tubule. So here's my nephron tubule again. My simplistic drawing. And if I look at my blood vessels, here comes my blood vessel in. We said this is afferent. This is efferent. And what my efferent blood vessel does is it comes out, it runs along the proximal convoluted tubule. It runs along the distal convoluted tubule, and it makes this big giant loop that mirrors my nephron loop. So it kind of does this. This is called my countercurrent system or pattern. So your blood vessel, my filtrate's going this way. My blood vessel goes the exact opposite way. It runs countercurrent to my kidney tubule. So here comes my blood vessel. What it's going to do is it is going to either put in stuff or pick stuff up into the bloodstream that comes out of the kidney tubules, or it's going to put it into the kidney tubules. If we put it into the kidney tubules, what do we call it? Secretion, right? So I can either secrete it in or I can reabsorb it out. And as it comes out here, it may or may not go into the bloodstream. That's all going to follow concentration gradients, and we'll look at that. But by the time we get over here, we should be pretty much have tweaked our blood to where we want it to be. And now it's going to end up flowing out of the kidney here like this. All right. The only other thing I wanted to talk about before we flip to our PowerPoint, and I'm going to cruise through the PowerPoints pretty quickly and only talk about the important stuff on it. But I want to remind you that when I have this guy right here, really my distal convoluted tubule ends up over here like this, right? We kind of talked about this last time. And this guy, here's my afferent, and here's my efferent. And this guy right here, this would be my distal convoluted tubule. This would be the opening, the lumen for the distal convoluted tubule. And there's cells along here. There's cells in here, and there's cells in here. These are called the juxtaglomerular cells and the macula densa. Collectively, they are called part of the juxtaglomerular complex. So when we start talking about the juxtaglomerular complex, we're talking about these cells here and the macula densa. What do these cells do? A couple of things. If you remember up in here, we have baroreceptors and chemoreceptors. These guys are going to help with regulating blood pressure and my chemical composition. So for blood pressure, if my blood pressure is low, our heart doesn't like it when our blood pressure is low either, right? It affects our cardiac output. So one of the hormones that we're going to see secreted if our blood pressure is too low, if my blood pressure is low, is the hormone renin. Renin, I would say renin ramps it up. So renin is going to ramp up our blood pressure. What does that mean? It's going to turn up my hydrostatic pressure. Well, if I haven't had the ability to change my blood volume, I still have the same amount of volume. Can I increase my blood pressure in my glomerulus, in my little roundabout, without just adding more fluid or more volume to it? Yes. How do I do that? Well, you can see I kind of have this little pinching system right here between my distal convoluted tubule and my renal corpuscle. So if I need the volume to be higher in my glomerulus, one thing I can do is pinch off this side, not pinch it off, but compress it. I can make it constrict it. I can make it smaller. So if I constrict this and make this smaller, is that going to increase my hydrostatic pressure in my glomerulus? Yeah, because I saw volume coming in, but now I've basically made the leaving hole smaller. So if I make the leaving hole smaller, more blood's going to pile up in here, right? So one way that the juxtaglomerular complex works is it can adjust the outgoing cells of the blood vessels, of the nephron tubules, and we can up our blood pressure to our glomerulus. The other thing, we call it the RAAS system, renal aldosterone, renin, angiotensin aldosterone system. You don't have to know all that, just call it the RAAS. But one of it does is renin, and one of it is aldosterone. What does aldosterone do? Holds on to salt, which means I hold on to water. Is that going to change the volume? Yes. So both renin and aldosterone are going to boost. They're part of this RAAS system, which is going to ramp up my volume to my glomerulus. If my blood pressure's too high, we're going to dilate those and we're going to let the blood kind of crank out through there. High blood pressure is really, really hard on your kidneys because it's harder to adjust this down. One thing we'll do is we'll get rid of salt. So we'll put more salt in over here. If I put more salt in here, water's going to go in here, right? If I put more water in here, is that going to lessen my volume? Yes, because water's going to follow salt into the nephron tubule, so I'm going to get rid of my water. So one way I can decrease pressure is get rid of salt. No aldosterone gets secreted, and then we're going to see the loss of water through our urinary system. So we can adjust our blood pressure to help our heart, so your baroreceptors in your heart and your kidneys really work together to regulate blood pressure. All right, so let me look at, let's go to our PowerPoint here. And we've already talked about most of what you guys have to know. So let me just create this, right? That is the cortex, yes. I'm sure there's a few things I've missed talking about off the top of my head. So we'll flip through here and look. Okay, so what you should know, and I kind of start talking, and I'll slow down when we get there, but you should know the tissue types found at each of these. We talked about a lot of these in 201. Glomerulus and Bowman's capsule, what's my tissue type? Simple squamous. I can do rapid filtration, right? I'm going to get into columnar up here, cuboidal here, and a lot of cuboidal in this area. All right, so this shows my, these basically, just know these definitions. Excretion is the removal of metabolic waste. I didn't talk about everything. We are kind of naming some of the stuff, but we're putting metabolic waste in and we're going to pull good stuff that we still need back out. Elimination is discharge from the body. And the whole point is to keep our blood volume at homeostasis and our chemical composition of our blood at homeostasis. And if it's not, we're going to either get rid of it or pull it back out of the urinary system as much as we can. Everybody good? Well, you guys let me know if I go too fast. So we can regulate blood volume, blood pressure. We've talked about this quite a bit. One is by changing my volume of my blood in my body. If I want to make the volume of my blood lower to decrease blood pressure, I'm going to kick more out into my urine, right? More water is going to go in the urine. What's plasma mostly made up of? Water. So I can decrease my volume by eliminating water from my blood, basically filtering it out at the kidneys. What if my blood pressure is too low? I can add more volume to it by holding on to water. So some of our hormones that we talked about was ADH, aldosterone. We can do renin. We said renin will up it. Erythropoietin will up it. What does erythropoietin do? New red blood cells. If I add more red blood cells to my blood, I'm increasing the volume, right? Some of the other things it does is it controls plasma ions. Super important, right? Sodium and potassium we talked about with muscle contractions. Well, every cell membrane in our body uses sodium and potassium. So we have to have this perfect concentration of sodium and potassium. They do charges, electrical charges throughout our body. So if we get messed up on our ion charges in our fluids, it messes with sort of the electrical systems in our cells. Chloride's another big one, and you're going to see when we look at the urine, the kidney tubules, chloride is part of the trading system. Usually, remember on sodium potassium pumps, who's trading? Sodium goes one way, potassium goes the other way, right? We're going to see chloride go with them as well. So you usually see these three together, sodium, potassium, and chloride. And then calcium, we talked about calcitriol, calcitonin. We can get rid of excessive calcium by excreting it out. Urinary system helps to stabilize blood pH. How can I do that? By the ions that I hold on to, things like that. How important is pH level in our body? Super important. So we can either get rid of hydrogen ions, we can get rid of or maintain bicarbonate ions, which act as buffers. These would be our buffering system. All right, and the kidney, you should know, assists the liver for detoxification. And during starvation, we would see that we were kind of talking about this. The keto diet is not starvation, but it kind of begins to look the way if we were starved, your body would go to its fat, but it keeps a certain amount of fat reserves because the nervous system runs a lot off fat. And so if it gets to that fat level that it wants to maintain, then it will also go to proteins from muscles. All right, I'm going to skip through location. I'm going to assume you guys are pretty good with location. You don't have to know this. You should know what the hilum is. What is the hilum? Yeah, it's this part. We say it's kind of the pelvis. It's this part right here where stuff is coming in and going out of my kidneys. That's my hilum. And this shows your hilums right here. You don't have to know. You should know about the cortex and the pyramids. Everybody good? And the papillae. What's the papillae drain into? Yes, minor calyce or minor calyx. So it goes from this nephron tubule would be like this. Oops. And here would be my pyramids. And my collecting duct ends up coming down into the pyramids. It drains through the papillae into the minor calyce, major calyce, out the ureter. So the collecting ducts come right down into the pyramids, and then that's how they drain from the kidneys. Renal columns are just the spaces between my pyramids. So if this is my pyramid, this is a renal column right there between those pyramids. We're going to skip that. We talked about major calyci. Everybody's good on those. And we just call them branches of the pelvis. Is your major calyci is where all these branches come into bigger branches in the pelvis. But these would be my minor ones. Here would be my major, my papillae right at the tip of these pyramids. My nephron tubules, the collecting ducts, go right down into the renal pyramids. And this is what they look like in real time. You don't have to know this for the exam, but 20 to 25% of cardiac output we see in the kidneys, about 1,200 milliliters of blood flow through the kidneys each minute. So lots and lots. Our kidney blood comes from the renal artery, and then they get smaller, smaller, smaller. They go to interlobar arteries, arcuate arteries, then they become the afferent, efferent. And these are arterioles. All right, so this shows the arcuates go around the corners here, and then where they go up to the glomerulus, this would be our afferent. And this shows a nice picture. Here's our renal pyramids. All of these little circles in here would be our glomerulus for all these different arterioles here. This one actually has a nephron tubule, so this would be my glomerulus. You can see my proximal convoluted tubule, descending loop, and just barely, most of these are cortical nephron tubules. They barely go into the renal pyramids. This is what most of your renal tubules are, as they're up here in the cortex, but you can see they still dip into the medulla just slightly, barely. And we said that as we get closer to the medulla and into the medulla, it's going to be saltier, higher solute content. And then they would join right here. This would be my collecting duct. And you can see here, this collecting duct goes all the way down. They'll go out the papillae into the minor calyci. This shows kind of my blood vessel flow. You don't have to know about the nerves at all. Nephrons, everybody good with the nephron anatomy? Glomerulus, Bowman's capsule, proximal convoluted tubule distal. This shows your tissue types, which is really good. In here, we can see some of those cuboidal with microvilli and our proximal convoluted tubules. Simple squamous, we said these are going to be cuboidal all through here. The difference up here, these cuboidal ones have the microvilli, kind of like what we saw in the intestines. All right, descending loop, highly permeable to water. I think I said that these were columnar, and they're not. They're cuboidal with microvilli is what I meant to address, was the microvilli. So let me make that correction to what I think I said. I did say microvilli. Okay, good. For a second, I'm like, did I say columnar? I was afraid I might have said columnar, but yeah, they're cuboidal. Okay, down here, remember these are highly permeable to water. This is not permeable to water at all. This is permeable to solutes, and you're going to see how important that is here with our counter current. What does counter current mean? They're going the opposite direction, right? My filtrate's going one direction. My blood is flowing the other direction. And this concept of who's permeable to whom is really important with this countercurrent system. All right, podocytes. These are the ones that I was talking about. They create these filtration slits, which are the big slits. Why do we have those big slits? More stuff can filter in and out. So just be aware that this term podocytes, these create those big, well, relatively big compared to simple squamous cells that allow things to filter through there. And this shows my distal convoluted tubule. Here's my juxtaglomerular complex in here. These are called the mesangial cells. We have our macula densa in here. Here's our juxtaglomerular cells here that are controlling the size of my blood vessels in there. And this whole thing is called the juxtaglomerular complex. These guys are helping to regulate what goes in and out of here as far as like solute concentrations, but they're also regulating my hydrostatic pressure. We want this super consistent hydrostatic pressure in here. So if blood pressure is low, we're going to have to make some adjustments to keep this hydrostatic pressure normal. So we're still filtering things out of the kidneys at the right rate. If blood pressure is too high, we're going to make adjustments over here so we can decrease our filtration rate or our pressure coming into our glomerulus. All right, what do those mesangial cells do? And these are basically derived from smooth muscles. They're just kind of supporting filtration. They help to control the diameter of the capillaries. Controlling the diameter of my capillaries is going to help to control my hydrostatic pressure into my glomerulus. That makes sense, right? And I'll back up to the picture here in a second. I'll give you guys a second. That was everybody good with this? All right, so that's these guys right here. They're helping to tell these how to change to keep my hydrostatic pressure consistent in here. And an example is if my blood pressure is too low, we're going to constrict this side, which is going to cause more fluid to build up inside the glomerulus. All right. One thing to know is our really larger solutes like plasma proteins are not going to pass through those slits. They're not going to fit. So what's going to fit? Things small enough to go through the slits. We have what we call a filtration membrane, which is basically we have the cells from our glomerulus. We have the Bowman's capsule, and then there's kind of a membrane space in between, and I'll show you a picture of it here in just a second. We know what proximal distal convoluted tubules where they're at, right? Okay, so I'm gonna cruise through that. This is just showing you, but this is where our descending loop starts. This is where our ascending loop ends, and there are proximal and distal convoluted tubules beyond that. All right. We have some microvilli in the proximal convoluted tubule, actually quite a bit of microvilli. Why? What did I say happens mostly in the proximal convoluted tubule? Yeah, most of my reabsorption takes place in the proximal convoluted tubule. It's good organic molecules that we need, ions that we need, water that we need, things like that, vitamins that we need are going to come out of the proximal convoluted tubule. They're going to go into the peritubular fluid, and then so they'll cross this little fluidy space, and then they'll go back into the bloodstream up here. So right here is a good example of why the efferent arteriole runs so close to the proximal convoluted tubule, because we're taking good stuff right out of here, and we're going to put it back into the blood right there. All right, the last section we said is distal convoluted tubules. It is smaller than the proximal convoluted tubule, and it's epithelial cells, no microvilli. Why? We're not really absorbing that much here. We can absorb things, we can't secrete things, but remember, hormones are controlling it more than tissue type. So hormones are making those adjustments here. Juxtaglomerular macula densa, be kind of familiar with these terms, which we just talked about. What are they doing? One of their key things they do is regulate blood pressure into the glomerulus. Why? So I get constant filtration. If I don't keep my blood pressure constant in my glomerulus, it's going to affect my filtration rates. Either they're going to be too high or too low, which is going to mess up my blood, the homeostasis of my blood. So it's really important that I have this really consistent filtration rate. All right, so macula densa, this is my chemo and baroreceptors. We kind of talked about that. These juxtaglomerular cells, they're baroreceptors, they secrete renin. What's renin going to do? Ramp up my blood pressure, right? Extraglomerular cells, we just talked about those guys. All right, and here's a picture of them again. All right, collecting duct. These are kind of final. The collecting duct is influenced by ADH. What's ADH do? No, that's aldosterone. Antidiuretic. Yeah, antidiuretic, and it opens up pores, really affects the collecting ducts and kind of takes the last of the water out of there. But you're right, they're both dehydration hormones. But aldosterone says hold on to salt, which makes us hold on to water. ADH just opens up the pores so that the water leaves the tubules. The collecting ducts drain into the papillary ducts. Where do I find my papillae? The bottom of my pyramids, right? And then where do they go from the pyramids? From the papillae, minor calyce to major calyce to ureter. What kind of tissues in my ureter? Transitional to my bladder. What kind of tissue? And to my urethra, which is it's stratified squamous. Yep, you got it. Good job, you guys. Okay, and this shows my collecting duct. A little bit of absorption going there, but all right, cortical. We know what these are now, right? What are cortical nephrons? Yeah, they're mostly up here in the cortex. They might just barely dip into the medulla. This is the bulk of my nephrons. 85% of my nephrons are cortical, are found in the cortex of my kidney. We have some that go deep down, more deep down into the medulla. These are my juxtamedullary nephrons. This is only 15%. We said that the vasa recta kind of loops down here in the nephron tubules around the efferent vessels and the nephron tubules. The peritubular capillaries are the ones found up high. So if I was looking at a vasa recta, I'd see them kind of along in here. If I was looking at peritubular capillaries, I'd see them up in here. This is a cortical nephron. You can see they're mostly in the cortex. Juxtamedullary come way down in the medulla. This is what most of my tubules are. And this shows my peritubular capillaries up here. These are my vasa rectas down in here. They use vasa recta more on the deep juxtamedullary ones than usually on the cortical ones. They tend to call them mostly peritubular capillaries. And then these ones where they really dip down in the medulla, they tend to use vasa recta more on those. All right. A few metabolic wastes: urea, which is an organic waste; creatinine, which is the breakdown of creatine phosphate, which is the storage molecule for energy in muscles, is one place we find it. And then uric acid is recycling of nitrogenous bases. So organic waste get dissolved into the bloodstream. They travel through the kidneys to the kidney tubules to the renal corpuscles into the kidney tubules, and they get excreted. A lot of times with higher uric acid, that's where we'll see those uric crystals can build up and cause issues like gout. Is usually uric crystals. So we're just not getting it filtered out of the kidney and it shows up. It tends to accumulate in joints and things like that. So, All right, so our kidney's job is to produce concentrated urine, 1,200 milliosmoles per liter. You guys remember what milliosmoles when I tortured you with all those solution worksheets and we had to do milliosmoles? You guys remember that? So this is, most of the stuff in the blood is measured in milliosmoles. So, and basically, remember when we were looking at osmoles, we were looking at how many particles are in the blood and where's the water going to move based on the particles. All right, we have to concentrate or filtrate. Why not? We would fatally dehydrate and die within hours. Why? Because one of the main things that goes into the nephron tubules at the glomerulus is water. Tons and tons and tons of water. If we didn't pull it back out, we'd be drinking gallons and gallons and gallons of water just to keep our blood volumes up. We would die very quickly. So one of the main functions of the kidney is to pull all the water back out of the filtrate and put it back into the bloodstream. It seems a little inefficient, but it works. All right, just know these terms. I've talked about them a lot. Filtration is just using that hydrostatic pressure to move things from the bloodstream in the glomerulus into the nephron tubules. That's our filtration. Reabsorption is when we pull it out of the kidney tubules to go back to the bloodstream. Secretion is when we take it from the bloodstream and we put it in the kidney tubules. We call that secretion. And then we had elimination. What is elimination? We get rid of it at our bladder, or excretion. Elimination or excretion. Okay, so on this, what do I want you to know? I would just look at these to give you a really good idea as you study of what is moving where. I think I've really addressed the super important things. But if you look at, so green, we're just filtering it based on pressure. When we get to proximal convoluted tubules, if you go down here to the key, water is one of the big things that comes out of the proximal convoluted tubules. And solutes, we talked about that. Important ions, things like that are going to come out of the proximal convoluted tubules. We might do a small amount of secretion. As we go down here, we said these are highly permeable to water. So we see water coming out. As we go, these are not permeable to water, but they are permeable to solutes. So solutes can go out or come in as needed. Distal convoluted tubules, we see most of our secretion take place in the distal convoluted tubules. So we're going to take things from the blood and put it in here. These guys are really under hormonal control. And then our collecting duct, we can kind of fine tune everything. Okay. So this just shows your podocytes making these filtration slits, which I kind of talked about. This is the membrane between, so when we look at this, this is going to be my blood, and this is going over to my kidney tubule into Bowman's capsule. And this big filtration slit is where things go into Bowman's capsule. All right. Hydrostatic pressure versus colloid osmotic. We talked about hydrostatic. It's just cranking up the volume, right? It's like having a hose with holes in it, and we turn the volume up, and whatever fits out the holes goes. That is what hydrostatic pressure is. That is how we filter things at the glomerulus. This is solely hydrostatic pressure right here. If it fits, it goes. We do have some counter. I always think of the counter pressure too as a drain. If I had a, like in your bathtub drain, when we pull the drain, everything doesn't gush down at one time, right? Why? Because it's a little space, and as the pipe fills up with water, there's a little bit of pressure coming back, which makes it where they kind of have to wait their turn to go down in there. So as they're waiting their turn to enter, the fluid's waiting its turn to enter into the nephron tubules, it's providing a little bit of counter pressure. So not every single thing goes because we have a little bit of counter pressure. But our hydrostatic pressure in our glomerulus is higher than our counter pressure. So we're ultimately going to push stuff into the nephron tubules. What is our colloid osmotic pressure? Particles. Things are going to move. Water, liquids are going to move to, or solutes are going to move based on the concentration gradients, right? So that is our colloid osmotic pressure. All right, glomerular hydrostatic pressure, we talked about that, so I'm going to skip through that. We talked about the hydrostatic pressure in the capsules. I'm not going to ask you a ton of questions about that, if any. I just want you to understand the glomerulus filters by hydrostatic pressure, and we have some back pressure just from the fluid. That would be basically our capsular hydrostatic pressure. It's waiting its turn to get into the tubule. Colloid is basically our solutes. Where do we have solutes? If solutes will fit, solutes can go. But we said here, this is not permeable to solutes, so solutes can't move, which means they're going to stay in the tubule. Water's going to go wherever it needs to go based on the concentration gradients. This is permeable to solutes, but not to water. Here's where we might see solutes move, but they're going to move down their concentration gradient if they can go, and it depends on the tissues. Do the tissues let them move or not? This just shows my back pressure. So my back pressure waiting to go down the drain is 25. My filtration is 50. And I also have another capsular hydrostatic pressure, and this is my blood colloid osmotic pressure. So I'm filtering about 10, which is my glomerular filtration rate. This is overall, how much is moving? All right, what controls that glomerular filtration? Hormones, the autonomic nervous system, and those baro and chemoreceptors right at that area that can tell those vessels get smaller, get bigger. Right, we talked about these guys. I'm going to skip through here. The RAAS system that I was talking about helps to control the amount of volume in our blood, which ultimately controls blood pressure. So this is the RAAS. We know renin ramps up our blood pressure. Aldosterone says hold on to salt. If I hold on to salt, I hold on to water. Is that going to ramp up my blood pressure? Yes. So this whole system is about increasing blood pressure. All right, so I want you to know that our juxtaglomerular complex releases that renin. When do we see this? If we get a decrease in blood pressure, then we're going to increase basically hydrostatic, or we're going to decrease our osmotic pressure. Colloid osmotic pressure is the number of particles. How can I make the concentration of particles less? Add more fluid to it, right? So these are going to increase my fluid. All right, I'm not going to ask you about this. The only thing I will say is anytime, oh, it's not even on here. Oh, here it is. You have angiotensinogen. This is floating but inactive, right? And then I'm going to turn it into an active enzyme. How do I do that? We use a converting enzyme, which is ACE. You may hear of ACE. They'll use it. We said that basically all of these together are going to hold on to salt, make us thirstier, things like that, which is going to increase our volume. I don't ask you a ton of questions about it. The big thing is know what aldosterone and renin do. I don't ask you all those sympathetic, all that stuff. Natriuretic peptides. These are when I have too much blood volume. So my blood pressure is too high, my baroreceptors pick up, hey, blood pressure is too high. We need to decrease blood pressure. These guys are going to help decrease my blood volume. How can I decrease my blood volume? get rid of salt, right? If salt stays in my kidney tubules, where's my water going to go? Into my kidney tubules, and I'll excrete more water, which will lower my blood volume levels. So your kidneys are really, really tied to your blood pressure. And one of the big risks of high blood pressure all the time is renal or kidney failure. Why? Because we're constantly putting too much hydrostatic pressure on our glomerulus, which could lead to kidney disease. All right. So renal tubules, we're going to reabsorb helpful things. Most of our water gets reabsorbed. 90% of our water gets reabsorbed. From what filters here, 90% of it gets reabsorbed and put back into the bloodstream. We just said we would dehydrate and die in hours if that wasn't the case. If we have any waste that are left in the bloodstream that didn't get put into here, we can secrete them into there. We can, actively transport those right into the kidney tubules. All right. Diffusion, osmosis, leak channels, carrier mediated transport. Diffusion is moving down the concentration gradient, right, of a solute. So if I have more solute on one side and it moves because of the concentration gradient, we're going to use diffusion. Osmosis is where water moves to where the higher concentration of particles are. Leak channels allow things to leak down the concentration gradient, usually at a slower rate, but they go through a channel. Carrier mediated means I have to put them in some sort of protein that carries them over to the other side. Oftentimes, this is an active transport. So we have facilitated diffusion, which is not active transport. We have active transport, co-transport, counter-transport. I am not going to quiz you. I used to do this, and I've gotten nicer as I've gone along. I used to make them know what kind of transport was happening in each portion of the tubules, but for the sake of time, I didn't ask you any questions about that. So you don't have to worry about studying that. All right. Okay, a couple terms just to know. If I have too much glucose, we call it glucosuria. 180 milligrams per deciliters. Anything over that is considered too high of glucose. Amino acids, we may see some amino acids after meals, maybe with high protein diets like keto diets, things like that. We may see some amino acids. We should not see excessive proteins in the urine though. So amino aciduria is one of those, glucosuria. So those are high glucose, high amino acids. Is everybody good? And this just shows you some of the stuff that here's our waste, here's good stuff that we're holding on to. Again, I'm not going to quiz you on this, but it's not a bad idea to just know it. Proximal convoluted tubules, we said 60 to 70% of reabsorption happens in the proximal convoluted tubules. It enters the peritubular fluid. What is that? That's the fluid outside of my nephron tubules, but not in the bloodstream. It would be like interstitial fluid, but it's what we find here in the kidneys. We call it peritubular fluid. And then it's going to diffuse into the peritubular capillaries. So it goes from here into my peritubular fluid, and then it can go into the peritubular capillaries. Proximal convoluted tubule, we know its function now, right? We're experts on it. Water, ions, organic materials, vitamins. We can do some amount of secretion. All right. And I'm not going to ask you all of this, so I'm going to flip through all this. I talked about descending, freely permeable to water, but not to solutes, right? And this is freely permeable to solutes, but not to water. Distal convoluted tubules, we said, is not going to be a lot of reabsorption of filtrate. These guys are going to be what hormones influence the most is my distal convoluted tubule and a little bit of my collecting ducts. By the time we get to the distal convoluted tubules, it looks quite different. Here we do active secretion. What's secretion? I put it into, right? So what kinds of things do I secrete into the distal convoluted tubule? Maybe some ions for some final adjustments, acids, drugs, toxins. So if they didn't get filtered, our blood vessel here will secrete them right into the distal convoluted tubule. Okay, we will see sodium and chloride go one way, potassium goes the other way. So remember how I was saying they trade? Usually if we trade a sodium, chloride goes with it, potassium goes the other way. So if I moved sodium into my tubules, chloride is probably going to go with it, potassium is going to go to the outside. Likewise, if I take sodium out, chloride goes with it, potassium goes in. They always exchange with each other. So if you saw some kind of an issue where someone had messed up potassium levels, that means somehow we're trading sodium and chloride for potassium for some reason. So it can sometimes give you a hint as to what's going on. All right, and here you see that we see sodium and chloride are going out, potassium goes in. So they're just exchanging with each other. Aldosterone, what's it do? Hold on to salt. If we hold on to salt, we're going to hold on to water. Hypokalemia, this is dangerous reduction in potassium concentration. Why would we see this if we have prolonged aldosterone? What would happen if I had too much aldosterone? It comes constantly affecting my distal convoluted tubules. Who's it saying to come out of the tubules? Aldosterone says what? Hold on to what? So, which means Na is coming out and chloride's coming out, right? So who's going in? Potassium, and potassium's going out into the bladder. So you can see we're losing all our potassium out of our blood. Why are we losing the potassium out of our blood? Because we're saying, hey, hold on to sodium, which means we're holding on to chloride, which means we're trading potassium for sodium. So this is one example of where we would see an ion. Remember, ions help to pass electrical messages across cell membranes. So if I don't have potassium, it's going to begin to influence all of my cell membranes. Atrial natriuretic peptide, or AMP, it does the opposite of aldosterone. And then parathyroid hormone, this affects calcium ion reabsorption. So when do we secrete parathyroid hormone? High or low blood calcium? Low blood calcium. So I would take it out of the distal convoluted tubules and put it in the blood, right? If I have parathyroid hormone. So all of these are going to be influencing right here at the distal convoluted tubules. Is everybody good? All right. So another thing that we'll see, I already said some things we can secrete in there if they're bad things in the blood. Our rate of potassium and hydrogen secretion rises or falls according to how much we have in the peritubular capillaries or peritubular fluid, right? That is the fluid on the other side. We're going to be trying to find that equilibrium. So if we have higher concentrations, we put more into. So if out here had higher concentrations, it's going to put more into there and we're going to get rid of it. So if our body was getting a little bit acidic, we would take hydrogen from here and it would go into the distal convoluted tubules, just down the concentration gradients. All right. That's all I want you to know about that. Aldosterone also stimulates hydrogen secretion, which can cause us to become really alkaline, which means our pH levels would get above that 7.45, which is not any better than being below 7.35. So if we have too much aldosterone, because it encourages the secretion of hydrogen ions, it can make our blood too basic. All right. How do you guys feel about ADH, aldosterone? You guys okay with those? All right. Countercurrent multiplication, or the countercurrent system, basically, I'm going to cruise through this because I talked about this already. You have to know who's permeable to what, and you have to know that our blood is going to flow the opposite direction of our peritubular fluid. So this is what happens with it. I'm going to kind of jump ahead because I don't ask you about the transport systems. But I think this is so amazing that our body does this. All right, remember how I told you the medulla is, I'm going to erase my bloodstream for kind of, let me just clean my picture up. So if I am going down my nephron tubules here, and remember how I told you down here is saltier, down in this part. All right, this is permeable to water. So as I go down, this is getting saltier. So as it's getting saltier, what's going to happen to my water? Water's going to come out, right? Because water goes to where my solute. But now I get really salty. So at the bottom of this, I'm going to reach homeostasis. My blood colloid, so the number of particles in my blood, has increased, right? Because I took the water out of it. So now, and the big stuff can't go. This is not permeable to solutes. So the solute state, I said bloodstream, my apologies, I meant nephron tubules. So as I took water out, my nephron tubules don't have very much water right now. They're mostly solute. Now as I go up, this is not permeable to water, but solutes can move. As I go up, this was homeostasis. As I go up, the outside is getting less concentrated, but my blood was really concentrated. So what happens to my solutes? They go out. So this half makes the medulla salty for this half to lose the water in. Isn't that amazing? So we don't become dehydrated because of this loop. And the water coming out is what creates this homeostasis. And then we lose our water because of the salty part that's coming afterwards. And that's what I like about this picture. When you look here, our blood comes in to our descending loop at about 300 milliosmoles. And you can see it's getting more I said blood, I'm sorry. The filtrate, it's 300 milliosmoles, and look, it's getting more concentrated. Why? Because water is coming out. So my outside out here is going to be more diluted up here, where a lot of water came out. I lost a lot of water by the time I got down here. When I get to the bottom or at equilibrium, now this isn't going to let any water out. So as I go up, I'm going to let my solutes out. And that's what makes this part get salty for this part. So that's what I want you to know about those. Our medullary osmotic gradient. Basically, the ascending loop is creating that high concentration. This side's creating this high concentration of solutes, and we lose water on this side. That's basically what this is telling you right here. All right, and this shows it a little more. When we get up here, we're back to 100, and then as we go down our collecting duct, because these guys are permeable to ADH, things like that, we'll lose water again. By the time we get out to our bladder, it's highly concentrated, very little water in it, relatively speaking. All right, now what's going to happen to our blood. Just a couple terms to know. Obligatory water reabsorption. This is just water movement that can't be prevented. It's going to move down the concentration gradient and it can go through the tissues. Facultative, this is where we can control it using hormones. So this is the obligatory. This is facultative over here. We know what ADH does. So I'm going to cruise through all of this. All right, here we get into our counter current. Our Vasa recta is part of what plays. I'm going to flip to the picture if that's okay, because if you guys understand the picture. All right, so I'm going to start on this side because that's the way my bloodstream flows, is like this. So if I go to this side, here comes my bloodstream right here. As stuff comes out of my bloodstream here, because I filtered a bunch of it out, my osmolarity is going to be extremely low coming into here. And as I go down, my osmolarity in my medulla is going to get higher. So I'm going to be taking in water as I go. So this is part of how I return water to my bloodstream. Oops, let me backtrack. And then this is the second part. As I go back up, again, we're going to be taking in water here based on the concentration gradient. So water comes out here. We got concentrated in our blood down here. Water's going to go in here. And you can see solutes are coming in here. So as we flow backwards, we use that concentration gradient to pick up solutes here, which concentrates my blood, which causes me to pick up water over here. So it's running the exact opposite way. So that is our counter current. All right. We do have peristaltic contractions to basically our bladder. Bladder, I want you to know, is transitional. We just talked about a full bladder can hold about 1 liter of urine. And here's our male bladder right here. Here's our female bladder in here. This shows the inner part of it. The muscle for the contraction of the bladder is the detrusor muscle. You guys feel good about this in the male urethra? You guys know what the prosthetic urethra membranous spongy. All right, and this would show it here. Here's my bladder, here's my prostate gland. This would be my prosthetic. Here's my membranous. Which gland is this? Yeah, bulbourethra or Cowper's gland. This is my canned peanuts right here. And then this would be my spongy urethra. What's this tissue called? Yeah, corpora spongiosum. What's this up here? Yep, cavernosum. Good. What's this? Testes. What's this? What's this? Vas deferens. What's this? You guys are superstars. You got it. Female urethra is super short, which is why women are so much more prone to urinary tract infections and things like that. Male, well, you can see, let's backtrack. For a male to get a urinary tract infection, we're usually going to have to back way up into here or all the way up to here for a bladder infection, which is most common bladder infection. And then when we look at the female, it just doesn't have very far to go at all. All right. I don't ask you about any of the reflexes. Incontinence is just inability to control urine. What happens when we get old? We get more calcium buildup in our nephron tubules, so they just don't filter and work as well. We reduce our glomerular filtration rate, which remember is the net amount moving based on our pressures at those glomerulus and Bowman's capsule. We're not as sensitive to ADH, which is going to make us more prone to dehydration, right? So older people get dehydrated more easily. I think I skipped this one, which I didn't mean to. Decrease in the number of functional nephrons. So some of your nephrons will be damaged and won't function. And then for urinary reflexes, your external sphincter is not as toned. And so it kind of starts out where people will cough or sneeze or laugh and they'll have little accidents from that. And it's just because that muscle is not as strong as it used to be. So pretty common. You also see some of these other health things that can cause issues with that. In males, urinary retention may develop. Oftentimes the prostate gland is the culprit. So if someone, I'm going to backtrack to the male picture. If a male has a prostate issue, we had a cadaver once that the prostate was bigger than the bladder. His prostate gland was so enlarged, and we have pulled the whole prostate and the bladder out, that it actually like engulfed the whole bladder like this. He was, he did have a tube, a urinary tube, and when he died, they just cut it off. So he obviously wasn't able to urinate on his own. But as this prostate gland enlarges, it can pinch on the prostatic urethra. And so they'll feel like, hey, my bladder's full, I have to go to the bathroom, because they do, because their bladder's full. But there's so much pressure pressing on the prostatic urethra that they won't be able to empty their bladder all the way. So oftentimes the prostate is the culprit in males. And then for females, I will say childbirth is hard. The baby sits right on your bladder. It can do damage to the suspensory ligaments and things like that. And sometimes, especially if a woman's had, where they've had their uterus removed, it can affect the suspensory ligaments. And so instead of the bladder being tipped, let me go back to the picture. So with this bit of a tip to the bladder, sometimes because of all the pressure and the damage to it, it flattens out or it doesn't tip. And then they'll hold on to fluid in their bladder. They just don't drain their bladder as well, which then leads to a lot of bladder infections. So sometimes they'll go in and do surgery, kind of re-prop that up, reattach the suspensory ligament and make the bladder tip. I think it's actually supposed to be good. You mean the muscles, the external sphincter muscles? Yes, it would. Yeah, if we get infection to the kidneys, so our question was, if we can't empty the urine out of the bladder, would it affect the kidneys? Yes, it sometimes that infection will back all the way up your ureters to the kidneys. Pretty bad if you get a kidney infection. Oftentimes really painful as well. So you want me to tell you my little horror story, my little bladder horror story? So I had a hysterectomy, and when I had my hysterectomy, my after anesthesia, my bladder wouldn't wake up. And so they made me stay in the hospital because they're like, you can't go home until your bladder wakes up and you can urinate. So I had to stay overnight. And the next morning, they pull the tube and they're having me drink. I'm still on IVs, and I mean, my bladder was full. I was in so much pain. So they finally came in and they're like, oh, we're going to recatheterize you because I couldn't get my bladder. I just could not wake it up. I was trying everything. They're like, putting my hand in cold water, running the sink, like all the little wives' tale stuff. And so anyway, they did that, drained my bladder, then started the whole process over. And of course, then they ended up pulling my IVs, but until then, they're running all these fluids, plus they're having me drink. Well, at one point, I was like in so much pain, and I thought it was from the surgery because I was like, I couldn't really tell if it was my bladder or surgery. And the charge nurse was super mean. She came in. I got to where I couldn't lay down. I was just standing like this. And she's like, "You're fine. You're just being a baby," and blah, blah, blah. She was so mean to me. And she's like, "Just lay back down." I was like, "I can't lay down. Like, it just hurts too much." I just stood there with my head on the side. And finally, the CNA's like, "Maybe we should do the Doppler on her bladder." And I'm like, "Yes, let's do the Doppler. Run and get the Doppler." So they come back, and when they Dopplered my bladder, they're like, "You're at 1.1 liters with Doppler." So they finally catheterized me, which you just saw, the bladder holds a liter. When they finally catheterized me and drained my bladder, I was like at 1.3 liters in my bladder. So then they had to call the doctor, and he's like, "Well, you probably damaged your bladder at this point." So then I had to go home for 3 days with a catheter to let my bladder heal. It was terrible. So that was my little bladder horror story. So, but when it was that full, that was excruciatingly painful. It was terrible. Yeah. Yeah. It was awful. It hurt. So you can actually burst your bladder by over distending it like that. Luckily, my bladder didn't burst. But anyway, well, after that, the charge nurse was a little nicer to me because I'm like, "You're not such a baby. You just almost burst my bladder." It was terrible. So anyway, by the time that I went back 3 days later, my bladder was awake. Thank goodness. But that was awful. All right. So that was super fast and furious, but how do you guys feel about it? Okay. Yeah. No, on Tuesday. So we won't have face-to-face lecture on Thursday. On Tuesday, I'll just cruise through the reproductive system about as fast as I did this. So it's the reproductive system. I really did 97% of it is anatomy. So I'll just hit exactly what I want you to know on it. I don't make you learn all the hormone regulations of the cycles and things like that. So it'll be pretty quick and easy. But I just, on this, I want you to understand the anatomy, how we control filtration rates, and really that counter current system. You guys feel pretty good about it? All right. See, look at, I got you out of here early.